Thanks so much, Shelley. Yeah, and I'll just give the quick update, and then I will hand it over to Jared in case there's specific questions, in particular on the sequencing from the H5N1 cases that we'll cover. So, if you could go to the next slide, great. So I just wanted to highlight, as we move forward into spring, hopefully, we continue to see COVID cases coming through. While the overall trends in the country look flat and conditions are improving in a lot of the Northeast, and particularly the northern Northeast, where in Connecticut, New Jersey, and New York, hospitalization and cases are falling, sometimes as much as 15% or more in the past few weeks. States out west, like us in Nebraska, are seeing cases and in particular hospitalizations rise notably. And so while it does feel like COVID cases might be evening out, they are still high, and they are still particularly high in our region, probably even more extreme than the data show from these trends, just given the lack of testing we're seeing nationally. And just one other thing I wanted to highlight on COVID cases around the nation. So the bivalent booster shots are continuing to be available. They were designed to target the Omicron subvariants BA4 and BA5, which have previously been the dominant version of the virus. But since, as Joe Farrer noted last week, I believe it was, BQ1 and BQ1.1 have become dominant. So there's going to be continued focus on updating those boosters. Next slide. When we're talking about COVID, I think one thing we never steer too far away from is the use of masks and their value. And I think Dr. Lawler would be upset at me if I didn't highlight this systematic review from the Cochrane group on physical interventions to interrupt or reduce the spread of respiratory viruses. In particular, this study has been getting a lot of quotes around masks and sort of how they do and don't work. So this was an update to a 2020 review, and it's the latest study, so to speak, to suggest that face masks don't work in the community, but there's a ton of problems with the methodology and really the overarching assumptions that they make about transmission and how COVID transmission works. So this review and the approach to the systematic review assumes that that randomized controlled trials, or RCTs, are really the best evidence we have. And in particular around masking, we've seen that that's just not always the case. So they've combined results from multiple RCTs to get an average effect size. But the value of RCTs is different depending on the type of question you're asking. And so a mixed method approach in a lot of these situations is actually better than that gold standard of the RCTs. So, we know that face masks and respirators work in two ways. They protect the wearer from becoming infected, and they prevent individuals who are wearing the mask from spreading their germs to other people if they are infected themselves. And really most of the studies in this review only focused on the protection of the wearer from becoming infected. And in particular, they mixed studies across different types of masks. So looked at surgical masks versus N95s and KN95s. And what we know is those types of masks have really variable effects in how they protect and when they protect and why they protect. So they combined a bunch of studies that really addressed different questions and didn't really think about how COVID spreads, both in the healthcare setting and in the community, and how masks work. So next slide. You'll see when you look at some of the studies that they actually cited, that a lot of the evidence actually that they've combined really shows that masks do reduce the spread of COVID, and that we have strong evidence to know that respirators in particular protect us against respiratory infections. It's why we use them. We have studies in laboratory setting, in healthcare setting, and in community setting. And there's been a bunch of articles that sort of take down this review and I think one of the ones that I saw that was really hit the point home is that really all they've studied here is the value of adherence to masks, not and the importance of adherence to masks, not the effectiveness of the masks themselves. So a lot of self-reporting of mask usage, a lot of effectiveness studies combined in various settings, and a lot of effectiveness studies combining different types of masks, all lead to public conclusions being taken away from this study that masks don't work. And this, from my perspective, has really done a disservice to the value of masks and the ongoing communication around masks and respirators in the popular media. Next slide. The next thing I just wanted to highlight, we're sort of doing a world tour today, is the latest disease outbreak news from the WHO. So new cases of Marburg virus in Equatorial Guinea. These cases were first identified on February 7th of 2023. And actually, if we could go to the next slide, if you don't mind. So these cases were first reported on February 7th, and then the first and only RT-PCR positive confirmed case was February 12th. So just a couple things to note about this outbreak. As of the 21st of February, they've identified 9 cases. However, that includes 1 confirmed case, 4 probable cases, and 4 suspect cases. The probable and suspect cases died and were buried before they could have specimens tested. So really only one of the cases was tested. However, they do have epidemiologic links and have been classified as probable and suspect cases. The disease outbreak news alert from the WHO notes that there are 34 contacts being followed from this outbreak. However, it doesn't note how many alerts they're following. So we don't have a sense of the broader potential of this outbreak. However, we haven't had any outbreaks since that PCR positive confirmed case. Luckily, even though one of the cases did seek healthcare and passed away in a health facility, there's been no additional cases among healthcare workers, and this is really important because it means that we haven't seen that nosocomial spread, which is high risk in these types of outbreaks. But in addition, the DAWN notes, the disease outbreak news alert notes that they are having trouble with the follow-up of the contacts of these 9 individuals. So we're in sort of a wait and see space for this outbreak. One thing that just directly relates to the preparedness domestically and here at UNMC is that we spent a lot of time during the Sudan virus disease outbreak, preparing our laboratory capacity to test for these cases should they enter into one of our facilities. And all of the regional emerging special pathogens treatments across the US have testing capacity for Sudan virus disease that was stood up during that outbreak. And most, in fact, of the sites that turned on that capacity, so most of our regional treatment centers, also validated a target on the same device for Marburg virus disease. And so our capacity to test for Marburg virus is higher than it was higher than it was last year. So we have capacity across all of our regional emerging special pathogen treatment centers to be able to turn this on, and many of them already have gone through the verification process and turned this on. So we will continue to watch this outbreak and see if new cases emerge in the community or report to healthcare facilities. Next slide. Just a new outbreak of Lassa fever as well. And actually, I might not classify this as an outbreak, but rather 2 new cases of Lassa fever in Ghana and Accra. So this press release came out just a couple of days ago on the 24th of February. Both of these cases reside in Accra, which is a large city. And if we could go to the next slide, have just a couple more details about this set of 2 cases. So the Ghana Health Service confirmed the 2 cases. So they've gone through their testing and have tested positive for Lassa. The first case was a 40-year-old trader, sick for 2 weeks, who died at the teaching hospital there in the city. And then the second case is a contact of the first case. The second case is still alive and is being treated in the hospital. And so far, across those two cases, there's been 50 contacts that have been identified and are being followed up. So we will continue to observe this outbreak. Lassa is endemic in several countries, and we are continuing to see high cases across Nigeria, and now we see these cases in Ghana. And so having preparedness on the domestic side as well for potential imported cases is really important always, but especially this time of year when cases continue to grow. Next slide. And then we head to Cambodia for 2 new human cases of H5N1. So a second DON was released this week from the World Health Organization. These disease outbreak news items highlight concerning outbreak cases, outbreak events, or outbreak situations. And so this one flagged the 2 recent human cases of H5N1 in Cambodia. The first case was an 11-year-old girl who unfortunately passed away. And the second case was her father, who was asymptomatic but tested positive as a contact. And if we could go to the next slide. So I just wanted to highlight, before we get into a little more detail of those cases, we at GCHS have been tracking, thanks to Claudine Miller, all of the reports of H5N1 that we can identify in humans and animals across the globe. So these come from a variety of sources, and Claudine, who runs the newsletter, but also this map, continues to validate data coming into her from official and unofficial but validated reports to track H5N1 in animals and in humans. So this is available in the Global Center for Health Security website, which I can put in the link to the chat. Oh, thanks, Stephanie. Next slide. So just heading back to focus on H5N1. So it's circulating in birds in 2 forms. HPAI, or highly pathogenic avian influenza, and low pathogenic avian influenza. And the HPAI form is what we're seeing causing severe disease in birds. And we're seeing a lot of culling. So this is standard practice with HPAI to save other birds, larger flocks, to protect humans, to protect other mammals, and oftentimes can result in massive economic losses as flocks are culled. In the United States, we've seen over 58 million birds affected in almost every state in the United States. And just as an example, Butler, Knox, and York counties have had over 3.5 million birds affected in this outbreak. We do see sporadic cases of H5N1 in humans, and there is a high mortality associated with it, but not a lot of human-to-human transmission. Oftentimes, these cases, almost exclusively, the individuals have close contact to poultry or birds, which was the case in these Cambodia cases. So since 2003, we've seen 21 countries reporting 873 human cases with a little over 450 deaths. And the first human case was in 1997. The US has had 1 case late last year in Colorado, although there's some question as to whether or not that person was infected or just had sort of H5N1 detritus in his nose. And then just as an example, in Cambodia, there's been 58 human cases with 39 deaths. So in this specific case of these 2 individuals in Cambodia, the first patient was an 11-year-old female. She was taken to a hospital on the 16th of February, admitted with severe pneumonia a few days later, and then died the next day. And the father was an asymptomatic case that was identified as a contact, but also working with birds, and there's been varying reports, but he's been either reported as asymptomatic or mild symptoms with a mild cough. Next slide. So I think a lot of people saw the CDC report and then some of the news reports that followed, but the Cambodian Ministry of Health put out an announcement that after virus sequencing, isolation and sequencing, they sent the samples to Institute Pasteur. They were sequenced and identified as a member of clade 2.3.2.1c, and that clade has actually been circulating in Cambodia since 2014, and so not explicitly. The announcement was that it was not specifically related to this outbreak, and that has been circulating for several years and is endemic in Cambodia since 2014. So we will stand by and wait to see what happens with this specific set of human cases. And the sequencing is available on GISAID if people are interested. And the reports, sort of the expanded reports around the science, continues to be made available as the work is being done with colleagues through our Centers of Influenza funded by NIAID and the Cambodian Ministry of Health. So I think with that, I'll leave it, and happy to take any questions that are out there, and also we'll flag that my colleague, Dr. Jared Evans, is here to answer any of the harder sequencing related questions.
Thanks so much, Lauren. Jared, we'll put you on the spot for any comments you may have before we open it up, and anything you would add.
Just to echo what Lauren said, is that it hasn't been shown to be any kind of human-to-human transmission. Bird contact is relatively common in a lot of locations where these cases pop up, in particularly backyard or home farming, which don't have a lot of the regulations. So it's, as Lauren said, just a wait and see to see if there are any other cases that emerge from any contacts with these two individuals.
Great, thank you. And you might wonder why we're sharing all of this today, because everything international can become domestic here in a quick plane ride. So it's important that we're all prepared for these things, et cetera. But the H5N1 is actually the first pathogen. If most of you out there have been around for a while, you'll remember us doing our initial pandemic planning around this very pathogen. So it's interesting to this point that we're still talking about this. So, and thanks, Lauren, for the Cochrane report, more in-depth review.